Good morning, everyone, and welcome back after the coffee break. I'm sure after the coffee, you people are warmed up, more alert, and ready to continue with the journey of fertility management. Please tell me if I am very loud. There is always a ray of light, even in the thickest forest, and so is the ray of hope in every couple's life if they are facing with fertility problem. You all will agree with me that in last 2 decades, there has been tremendous advancement in the field of infertility management by IVF techniques, while the surgical techniques and training in tubal and uterine microsurgery is lagging behind. In fact, surgical management is comparatively less expensive, and it also gives multiple opportunities for conception, which is more important in the countries or with the couples who are desirous of a large family size. In this presentation, we will be talking about various anatomical factors in female genital tract that can affect fertility, various available surgical intervention, and expected outcome. Broadly speaking, reproductive surgery. Sorry for the interruption because I don't know, I have a small head, small brain. My mic is moving away or it is becoming too close. I'll hold it in my hand. That's better. Is it okay? Yeah, better. So if there is any issue at the level of uterus, fallopian tubes, ovaries, or the peritoneal factor, there will be adverse reproductive outcome. One of the important tubal factor is pelvic or peritubal adhesion, which could be secondary to pelvic inflammatory disease, maybe history of previous pelvic surgery. It can be appendicectomy, ovarian cystectomy, surgery for ectopic pregnancy, or various others. Peritubal adhesion can also be associated with endometriosis, and we know that adhesions, they affect tubal motility, ova pickup, thus fertilization and conception. It could be maybe mild tubal adhesion, or it can be severe enough to completely obliterate the pouch of Douglas. In these cases, the management option is laparoscopic adhesiolysis if the facility and the skill is available. But of course, in the cases where there is extensive adhesion, then IVF might be a better option. We can come across tubal occlusion. In most of the cases, it is distal tubal occlusion at the femoral end. And in some, we can find even at uterotubal junction or cornual end. Block can be there at any site, but generally that is secondary to tubal sterilization procedure. Whenever we see on hysterosalpingography, there is proximal tubal block, then do not take it on face value, because in almost 1/4 of the cases, it can be just because of tubal spasm. In 1/4 of the cases, it may not be a true block, maybe only tubal spasm. So in these cases, what is to be done? We can do selective transcervical tubal catheterization under fluoroscopic guidance. It has very high success rate, and they say that more than 90% of the cases, block can be opened and spasm also can be overcome. Another option is hysteroscopic cannulation. The benefit is that we are doing it under direct vision, and the cornual part of the fallopian tube is opened up by introducing this very tiny thin catheters. The true cornual block, which is typically called as salpingitis ischemica nodosa, in these cases, the best answer is uterotubal implant by using microsurgical technique. This unhealthy portion of the fallopian tube, which has become nodular, replaced by fibrous tissue, is being excised, removed, and implanted into the uterus. The block, it is possible to have block at the femoral end. Maybe rest of the fallopian tube is patent, and it is only phimosis at the femoral end. So what can be done here? Here the answer is laparoscopic fibroplasty. It's a very simple procedure in expert hands. Laparoscopically, identify the fibral end of the fallopian tube, introduce a Maryland grasper with the closed ends, closed jaw, and while taking it out, just distend it, dilate the fibral end, and it opens up beautifully. In some cases, there might be more severe adhesion and may need more, dissection. Sterilization reversal is the most successful surgical reconstructive procedure. And of course, the success rate depends on many factors. Younger the patient, better is the outcome. The technique of sterilization procedure used, like it is best if it was done by Pomeroy's technique, and worst if electrocautery or fulguration has been used. Tubal length matters. If it is more than 4 centimeters, then in almost 70% of the cases, there will be successful outcome. Even diameter of the anastomotic ends are important. If it is too much discrepancy, then results will be poorer. So recanalization, that is tubal anastomosis, can be done either by laparoscopic or laparotomy, any of the techniques, any of the approach. In expert hands, both the approaches have almost equal result. Laparoscopy is preferred because of its obvious benefits on the patient in postoperative period. It is believed that the fluid collected in distended dilated hydrosalpinges is toxic to the embryo. It is also believed that it can even flush out the embryo from the uterine cavity, thus affects implantation. There are management options like conservative management could be a choice in young women with mild distal tubal disease. Terminal salpingostomy might suffice. Some IVF centers, they have even used only antibiotic before IVF. They also claim to be higher success rate in minimal tubal disease. When there is a gross dilatation of hydrosalpinges and patient is not suitable for any surgical intervention, in those cases also, aspiration of the tubal fluid by transvaginal ultrasound, which is done at the time of, generally at the time of OVA pickup, has improved success rate. It is now accepted that the presence of hydrosalpinges reduces the success rate with IVF by 50%. And there is strong recommendation that do salpingectomy before you take the patient for IVF, or at least block the cornual ends of the fallopian tubes either laparoscopically or hysteroscopically, so that there is no leakage of this fluid and to affect their implantation. The management and results depends on the degree of tubal damage. In conservative management, it can be very variable, could be as low as 0 if the rigid thick fallopian tubes with loss of mucosal folds are there. It can be as high as 80% if there is minimal tubal damage. But of course, in conservative management, there is higher risk of ectopic pregnancy. Salpingectomy, we know that before taking patient for IVF, it is recommended to do salpingectomy if patient is agreeing for that and is suitable candidate for that. Especially those hydrosalpinges which are gross, enlarged, and are visible on ultrasound. So just to summarize, a young woman with mild to moderate pelvic adhesion, minimal tubal pathology, or blocked fallopian tubes could be a better candidate for early surgical intervention, while a woman more than 35 years of age or having long history of infertility or severe pelvic pathology could opt for IVF directly. Uterus, the site from implantation. It has a virtue of distending itself to accommodate the growing fetus. So if there is any anatomical issue here, it will affect its function as well. It could be because of either congenital uterine factors or acquired. So before talking about congenital anomalies, we'll quickly revise the embryology of the female genital tract development. We know that uterus, fallopian tube, cervix, and upper third of vagina develops from paired Mullerian ducts, that is paramesonephric ducts. During embryological life, these two ducts come closer to each other and then they start fusing from down to up caudally. After fusion, in between the septum, it gets absorbed. The lower two-thirds of vagina develops from urogenital septum, and after complete development, this septum also gets absorbed. So we get open ends of this non-fused paramesonephric ducts as fallopian tube, uterus, cervix, and vagina. Mesonephric ducts, they run parallel to paramesonephric ducts, and they are responsible for the development of renal system. In general population, the prevalence of congenital uterine anomalies is not so high. We can say it about 6% of the cases we can see, but it becomes as high as 25% when we investigate these women who have presented with either poor pregnancy outcome or along with history of recurrent miscarriage along with infertility. So how does it affect fertility or reproductive outcome? Maybe because of the smaller uterine size, poor musculature, and because of poor musculature, there will be impaired ability of the uterus to distend or accommodate the fetus. There could be abnormal myometrial cervical function, poor blood supply, poor endometrial development. Various classifications have been proposed to describe these uterine anomalies, maybe in late 18th century since then, but none of the classification is 100% accepted worldwide. For all practical purposes, this classification, which is proposed by the combined working group of European Fertility and Gynae-Endoscopic Society, here they have classified uterine anomalies from 0 to 6, separately vaginal anomaly and cervical anomalies. It is important to diagnose, identify correctly the uterine anomaly and classify accordingly, because it will help in future audit, study, and research purposes. So we all know this is the normal uterus. There is a small rounded bulge at the fundus. Arcuate is a normal variant. Generally does not lead to any fertility or obstetric issues, but sometimes there could be history of recurrent miscarriages. If there is non-fusion of Mullerian ducts, the paired Mullerian ducts, then there could be either bicondylar uterus, or if there is complete non-fusion, then double uterus or diadelphus. Here uterus, cervix, and sometimes there is longitudinal vaginal septum dividing the vagina also into two. When there is no issue with the fusion, but septum has a problem, it does not get absorbed completely, then it can lead to septate uterus. The septa can be thick, fibromuscular, or can be thin, more of fibrous tissue, can variably divide the endometrial cavity. It can be partial septum, dividing a little bit, or completely dividing up, even up to the cervix. Here again, there could be associated vaginal septum. T-shape or infantile uterus, which is believed to be secondary to embryotoxic effect of diethyl acetylbestrol tablet, which is actually banned for last 3 to 4 decades, but still some cases of infantile uterus are still being reported. There could be maybe agenesis or hypoplasia of one of the Mullerian ducts. Only one develops with fallopian tube, cervix, connection to vagina. Other one may be absent, or hypoplasia of the hemiuterus called as rudimentary horn, with or without endometrial tissue, with or without communication to the developed part of the uterus. These cases sometimes may present as obstetric emergency if there is any pregnancy in the rudimentary horn. So to understand these anomalies in a better way, certain criteria has been proposed. Like in this 3D ultrasound, if we see and join an imaginary line between these two divergent cornu and drop a line in the center, this line in the center, if it is more than 1 centimeter, then it is biconvex uterus. And we can see also the outer surface of the fundus of the uterus looks like heart shape. Here there is a concavity. While in septate uterus, this remains convex. There is no depression here, or maybe a little dimple. There could be confusion between arcuate uterus or partial septate. So they say that if you join a line from one corner in the center and then with the other and look at this angle, if this angle is more than 90 degrees, that is obtuse angle, and also this depth from the fundus till this indentation is equal to 1 or less than 1 centimeter, then it is arcuate uterus. While in partial septate uterus, this angle will be less, acute angle or less than 90 degrees, and this length will also be more than 1 centimeter. The most common is one of the forms of septate uterus, followed by bicoordinate. For initial screening, 2D ultrasound or hysterosalpingography are good enough. Sensitivity and specificity increases if this ultrasound is combined with saline infusion sonography. But for imaging, 3D ultrasound transvaginal remains the gold standard. Another good alternative is MRI. Depending on the facility available, both are in fact expensive procedure. But it is worth spending before taking patient for surgical intervention like hysteroscopy, laparoscopy, for diagnosis or for operative purposes. Coming to management, most of these major uterine anomalies might be associated with renal anomaly as well. In about 30 to 40% of the cases, we know that paramesonephric duct and mesonephric duct, they run parallel to each other. And patient might present because of the complications of underlying renal pathology. In most of these cases, actually fertility is generally not the issue. Patient conceives, but is not able to hold the pregnancy, can have early pregnancy loss, mid-trimester miscarriage, maybe preterm delivery, abnormal lie, abnormal presentation, increased cesarean section rate, can develop hypertension, abruption, or preeclampsia just because of underlying renal pathology. The poorest outcome, reproductive outcome, is with the uniconvate uterus. Biconvate uterus generally do well, especially if this defect is not too deep. In uterus diadelphus also, they have seen successful outcome, but of course, preterm delivery and mid-trimester miscarriages and all are there. If there is a rudimentary horn with pregnancy or with complications like endometriosis, then might need surgical excision. Traditionally, in uterus diadelphus, clinicians have done abdominal metroplasty with the aim of joining the two horns, thus to increase the endometrial cavity and space. But it is not being recommended because there has not been noted to be significant benefit. Rather, there is a risk of rupture of the uterus if patient conceives. Septate uterus, if it is seen in association with associated with recurrent pregnancy loss, then hysteroscopic septum resection is recommended. It seems that it improves the outcome success rate about 70%. But its association with infertility cannot be guaranteed. There is not enough study to say that how much benefit a patient will get after septum resection in respect to infertility. T-shaped uterus also, hysteroscopic metroplasty has been done by some clinicians with the aim of improving the shape of the cavity and the size of the cavity, and they have claimed good results also. But it is a very rare condition, so there is not enough literature to prove whether it is required or not. Patient may present to us early, maybe several months after menarche, or because of the complaints of chronic pelvic pain or cyclical dysmenorrhea, if there is obstructed congenital uterine anomaly. Here, it is very important to diagnose it early and manage early. Otherwise, patient, not only there will be continuous symptoms to the patient, but it will also lead to endometriosis because these hematocolpos, hematometra can develop hematosalpinx and can lead to endometriosis, which can in due course of time affect fertility as well. So here the management is septum resection and maintain the patency of the vagina to allow the blood to drain. In septum resection, it can be done hysteroscopically, either by using micro scissors, laser, or by resectoscope using Collins blade or the loop. It's good practice that before taking patient to OT, if we can measure the length of the septum, either with the help of 3D ultrasound or with MRI. It will help us to know that how much do we have to cut. Also, it is good if we do under ultrasound guidance or laparoscopic guidance at the same time when we are doing septum resection to avoid the complication like uterine perforation. When we are doing hysteroscopy, it is advised to look sideways for the alignment of both the cornal ends, openings of the tube. That will tell us that how much more we have to cut. And it is better to undercut than to overcut and land into complication. And if a small part of the septum, less than 1 centimeter, is remaining, that will not generally affect the obstetric outcome. The other issue can come like after septum resection, scarring. So they say that scarring generally is not so much because the endometrial glands surrounding it, they grow fast centripetally and centrifugally, and they cover up the area. But there could be adhesions, intrauterine adhesions. So to prevent that, intrauterine stent or balloon can be put. So the most extreme of the Mullerian anomalies is Mullerian agenesis. Here there is a congenital absence of vagina, most of the cases, with variable uterine development. And the management will depend on the severity of anomaly. In most of the cases, here there is role of creating new vagina to give a patient relief in her sexual life. Fertility might still remain an issue. Among acquired factors, fibroid uterus or leiomyoma is very common. In fact, a woman once reaches the age of 50 years, almost 70% of the women will have some or the other type of fibroid uterus if they do ultrasound. But presence of fibroid does not mean infertility. In fact, in only 10% of the women, infertile women, fibroid might be seen when we are investigating. And in only 2.5 to 2.8% of the cases, fibroid could be a sole reason for infertility. But of course, the presence of fibroid significantly reduces the success with IVF. And also, it might not directly affect fertility, but it can lead to poor obstetric outcome because of miscarriages, preterm delivery, repeated episodes of red degeneration and pain abdomen, cesarean section, and all. So which are the fibroids which are mainly responsible for affecting fertility? This is some mucous fibroid, especially type 0, which is completely within the endometrial cavity, type 1, which is more than 50% within the endometrial cavity. Even type 2, which is less than 50%, distorting the endometrial cavity, also affects fertility. Intramural fibroids may be more than 6 centimeters or multiple fibroids. They may not directly affect fertility, but they also reduce the live birth rate by 21%. Generally, subserous fibroid does not have implication on reproductive outcome unless it is at the uterotubal junction and obstructing the fallopian tube. How does fibroid affect fertility? Might be because of the changing the shape of the cervix, thus the sperm migration, changing the shape of the uterine cavity, block at the fibril ends, occupying the endometrial cavity, maybe a large mucous fibroid sitting there, and thus does not allow implantation or the growth. So we have already talked type 0, type 1 need management. Here, hysteroscopic myomectomy is the treatment of choice. Type 2 also, hysteroscopic myomectomy can be done, but they may need repeat sittings, repeat operations. For intramural fibroid, any of the approach like laparotomy, laparoscopy, or robotic technique can be used. The advantages or disadvantages of various techniques are still not known. So it depends on the skill available and the facility available and the patient choice, of course. When we are looking for a patient with infertility or pregnancy issues, then we cannot overlook endometrial polyp. Its overall incidence is 10%. But when we see these cases who have infertility or a poor reproductive outcome, then the incidence is as high as 30 to 35%. Patient might be asymptomatic or can present with the history of abnormal uterine bleeding or can present with the history of recurrent miscarriages or infertility. And on investigation, we find that there is endometrial polyp. It is accepted now that the removal of endometrial polyp, it improves all types of conception modalities like natural conception, even intrauterine insemination, or even assisted reproductive techniques. But of course, there is still not enough evidence to say that what size of the polyp is important. They say if it is less than 1 centimeter, that it may not affect reproductive outcome. So what causes abnormal pregnancy outcome with endometrial polyp? Maybe the mechanical factor affecting sperm transport, embryo implantation. They also believe that there could be intrauterine inflammation because of the presence of these polyps. Also, there could be altered production of endometrial receptivity factor, that is glycodyline, which is believed to be very low in peri-ovulatory and implantation stage, and gradually it increases in normal conception. While here with endometrial polyp, it may not do the same. The site of endometrial polyp matters. If it is at uterotubal junction, then after polyp removal, the success rate is as high as almost 60%. Yeah, also, if they are multiple, the success rate after removal is 40%, you can say. The minimal effect is from the polyp, which is, sorry, I think I have, I'm going up, I'm going down. No, still more, sorry. Polyp. Yeah, the minimal effect is from anterior uterine wall polyps, but still you see, if you remove these polyps, still the pregnancy rate improves by 15% and successful outcome. Can be diagnosed on 2D ultrasound when it is being done transvaginally during proliferative phase, when the endometrium is thinnest. So that is the time when we should do ultrasound to detect polyp, not in secretory phase when endometrium is already echogenic and thick. We can do mistakes. And of course, sensitivity and specificity increases when it is combined with saline infusion sonography. Hysteroscopy, of course, is the gold standard. It is diagnostic as well as operative. So this is, we can see echogenic shadow of the endometrial polyp. So stands out more clearly if there is saline inside, 3D picture, and it's a beautiful picture in hysteroscopy. Polyp can be managed on as see and treat in OPD basis. After confirming that there is endometrial polyp on ultrasound, when we do office hysteroscopy, we can confirm the location and the site and size of the polyp. Then as blind procedure, polyp forceps is introduced and the polyp is avulsed and removed. Some clinicians, they also do curettage, but it is being said that in almost 10% of the cases, intrauterine pathology might be missed. Most of the clinicians, they prefer to do polypectomy in the operation theater using operative hysteroscope or resectoscope, using micro scissors, loop cautery, electrode morcellator. And the benefits are that here there is minimal damage to the endometrium and the complete removal of the polyp is ensured, and thus the recurrence risk also will be less. Coming to another important intrauterine pathology, acquired one, that is intrauterine adhesion, or commonly called as Asherman syndrome. These two terms are in fact interchangeably used. So these are the bands of fibrous scar tissue which forms within the uterus, leads to partial to complete obliteration of the endometrial cavity along with or only cervical canal stenosis. It also affects fertilization at all steps. Patient can present with a history of oligomenorrhea, amenorrhea, poor obstetric outcome, or even infertility. There is various severity of intrauterine adhesions, could be mild, minimal, or severe enough to completely obliterate the endometrial cavity. There had been, again, many classifications have been proposed. mild, moderate, severe, or type 1 to type 4. Generally, it happens secondary to intrauterine infection or intrauterine procedures. Among intrauterine infection, tubercular endometritis is one of the very important factors, which we generally don't see in, at least in Oman, but in other parts of the world, it might be more common. Intrauterine procedure like curettage or removal of products of conception, any procedure which is being done on pregnant uterus, we have to be very careful because it can lead to intrauterine adhesion. Even uterine compression sutures which are being used for control of heavy bleeding in postpartum hemorrhage management, that can also lead to adhesion. In fact, we have one patient with us who has developed intrauterine adhesions just after this one. In gynae cases, hysteroscopic myomectomy, hysteroscopic resection of the septum, this all can lead to intrauterine adhesions if we have not taken care of. I really do not know why my slides are running. Anyway, so sorry for that. Hysteroscopy is the gold standard. Here, the excision or division of the adhesions is being done under hysteroscopic guidance using micro scissors, laser, or electrocautery. The conception rate after dissection of these adhesions is as high as 60%. But that is true for mild to moderate cases of adhesions. In severe cases, patient might need repeated procedures, multiple sittings. There could be more of scarring. And also we do not know what is the status of a basal layer of the endometrium. That is important. If it is not damaged, then success rate will adversely be affected. So we have to prevent the basal layer of endometrium. We have to prevent the recurrence of adhesion. So to prevent recurrence, various methods have been used. Maybe we can put one intrauterine device after adhesiolysis, which should be inert device. And nowadays, the Lippis loop or inert devices are not so commonly available. They can be use of intrauterine balloon, the bulb of Foley's catheter, uterine stent, even estrogen therapy. And there are certain newer anti-adhesive barriers. They could also be used with good result. In recent years, stem cell therapy has given quite promising result, but it is still not in general use. As the, we can say the cesarean section rate is going high globally, there is a lot of traction on the cesarean scar defect and the complication or issues related to this. It is variously called as isthmocele, scar niche, scar defect, pouch at scar defect area. But whatever it is a defect in the previous scar site. Patient may be asymptomatic or might present with the typical picture of cesarean scar syndrome, where patient might have abnormal post-menstrual bleeding. It's typical that after period is over, still patient is having bleeding or spotting, which continues for pretty long time. Can have pain, can have secondary infertility. Patient may also present for the first time with a scar pregnancy. Whatever said and done, pregnancy is not contraindicated, even if scar niche is untreated. After any cesarean section, if we do ultrasound transvaginal scan, we will see some kind of defect at the scar area, can be mild or can be severe. So about you can say 40% of the cases, some defect can be seen. And it becomes more clear or pronounced if you do saline infusion at the same time. So what are the risk factors which can lead to scar niche? Of course, multiple cesarean section. Cesarean, if it is done during labor, especially if it is more than 5 centimeter dilatation, or if the scar incision on the uterus during cesarean has been given very low, it is believed that these low incision can entrap cervical glands or tissue, which can later on produce mucus and make the scar weak. Suturing techniques. Nowadays, it is being discouraged to use locking sutures, so it is not in practice. But still, they say that when you are suturing and you take large bite of tissues, that can also make the scar weak. Post-operative adhesions. They say that if scar gets stuck to the anti-abdominal wall, there will be traction on the scar with the abdominal wall, and the uterus fundus that got retroflexed, and that has another traction. So traction, anti-traction on the scar makes it weak. So how does it affect fertility? This area defect can be like a U shape, can be triangular, and it works as a conduit or a pouch where the menstrual blood or debris can get collected. And now it works similar to hydrosalpinx. If you remember that the hydrosalpinx fluid is believed to be toxic for the sperms and embryo and everything, and same way it works. So it affects embryo sperm passage, toxic to embryo, and thus affects implantation. Even in IVF cases, during ovulation induction, there can be intracavity fluid in about 40% of the cases. It can also create problem at the time of embryo transfer, because embryo catheter, this transfer catheter can be stuck in this. So when to say that this scar defect is significant, and it should be defined as a scar niche. A defect to be called as a scar niche, this depth should be at least 2 millimeter, and the residual myometrial thickness should be less than 5 millimeter. Then only we'll say that it is a scar niche or isthmocele, which is significant. Then how to manage it? It can be done either hysteroscopically or laparoscopically. Hysteroscopically, resection of this distal ridge is being done with the aim to align endometrial cavity with the pouch, this defect. And with the belief that now once it is aligned, the blood will not collect here and patient will get symptom relief. But what will be the outcome in pregnancy, that cannot be said after hysteroscopic resection. Laparoscopic resection can be done, identify the scar defect, excise that area, and then resuture it. But it's all indicated only symptomatic patients or when patient has infertility. Otherwise, medical management can be tried first. Uterine transplant, that is replacement of the uterus, has brought breakthrough in the management of absolute uterine factor infertility. Could be because of the congenital causes or acquired defects. The first successful uterine transplant was performed in Sweden in 2013, and in 2014, first live baby was born from this transplant. Since then, many uterine transplants have been done, but actually all cases are not being reported. One study says that till the end of 2021, in last 5 years before that, 90 transplant had been done with 50 live births. So it is to be remembered that uterine transplant is not intended to be permanent procedure. As soon as the fertility is complete, hysterectomy is to be done. Because any transplant patient has immunosuppressant medications, and there could be lifelong side effects because of this medication. So who is the right candidate or the recipient? The one who is mentally very keen and prepared to carry on with the major surgery and with the side effects of the immunosuppressant medications, and is also prepared that it may not work. Should be healthy enough to bear with all these kind of, tedious process and high risk. Who is the donor? Donor can be a cadaveric donor, can be a live donor. Cadaveric donors are not so commonly available, so it is live donor. The benefit of cadaveric donor is that now patient, because it's cadaver, does not go through any major complications or so. We are relieved from that front, but the outcome is better with live donor. So donor should be premenopausal with proven fertility, no previous uterine surgery, no uterine anomaly or issues with that, no metabolic disorder. This donor should be investigated in the lines of any other donor for any other transplant. Coming to procedure, step 1, the recipient undergoes IVF, and all the embryos, whatever are prepared, they are being frozen. Step 2 is a major procedure where we need a very good setup, well equipped and advanced setup with a large team of doctors, with highly skilled surgeons with their supportive team, and it takes several hours. The uterus with the cervix is removed from the donor and implanted into the recipient. And then the tedious process of anastomosis of arteries, veins, tendons, cartilage, that all goes on. Of course, there are many risks. Could be life-threatening, massive blood loss, maybe infection, and maybe side effects because of the anesthesia drugs, immunosuppressant medications or so. And most depressing complication is graft rejection. Also, there has been so many ethical issues raised by people because it is very high risk procedure and being done for a non-life threatening condition. It's not like renal failure, liver failure, heart failure. It is for a condition which has another alternatives as well, like surrogacy or adoption. So a lot of ethical issues are also being raised. Just to name endometriosis, one of the very, very important factor, anatomical factor affecting fertility, but this will be covered tomorrow. There's a long lecture on this one, so I will not talk about it. Ovarian drilling has already been talked about in the previous presentations. So a few words only about the fertility sparing or fertility preserving surgery, ovarian transplant or transposition, or even uterine transposition. So for those prepubertal, adolescent, or young women who are planned to undergo gonadotoxic therapy or maybe radiotherapy, pelvic radiation, in those cases to preserve their fertility, ovaries could be pulled out from the pelvis or they can be fixed at different sites away from the pelvic radiation. Some surgeons, they have also pulled the uterus up and fixed it to the anti-abdominal wall along with the ovaries just to save it from radiation exposure. Ovarian transplant has also been done successfully, either at the same site or over the forearm, or there are various other sites as well. So it is one of the alternative. We have already heard that there could be embryo freezing, oocyte freezing, ovarian cortex freezing and preservation. So an alternative to that, this method is also there. So to conclude, various anatomical or local pathologies, how does they affect fertility is still not completely understood. And also there is very limited surgical interventions are available. And there is not we can say that because of the rarity of many conditions, there is not well-designed randomized controlled trial to guide us that what is right, what is the right option, what is not. So in those cases, we can take some clue and individualize the management on the basis of patient's age, duration of fertility, subfertility, previous management taken, local surgical expertise, or some other factors. But I would like to say that tubal reconstructive surgery, the training should be an integral part of reproductive medicine. These actually we have already covered when we were presenting, so I will just skip it. The same. Thank you very much.